Hey guys, welcome to my YouTube channel. I am Aranas, a fourth year medical clerk, and I basically provide lectures to medical students. And I really hope that these videos would be able to give aspiring Filipino physicians an idea of what a medical student usually tackles in medical school. If you find these videos helpful to you, please don't forget to hit the like button and subscribe and click the notification bell to be updated of my videos, where I'll be posting new videos every week. This video is part of my approach series where I discuss the proper attack to a certain chief complaint, giving the appropriate questions to ask in history taking and certain PE maneuvers to consider. Diagnostic examinations and management will not be part of the discussion in this approach series. So for today, our topic is weight gain. Our proper approach to weight gain. When we say weight gain, the usual disease that we associate with it is obesity. And according to WHO, obesity is already considered a global epidemic. Let's always advocate a good patient education regarding this common chief complaint. Make patients realize that the best prevention of all diseases is through the avoidance of risk factors. And one of the most important would be obesity. For the topic outline, we will first emphasize the importance of body mass index. Then I'll be presenting to you the differential diagnosis for weight gain, followed by the history and physical examination approach for it. WHO recommended classifications of body weight, and these classifications are based on the body mass index calculated as the empiric English BMI formula of weight in pounds times 703 divided by height in inches squared, or the metric BMI formula of weight in kilograms divided by height in meters squared. Here is a table of cutoff values for BMI from WHO, comparing that of the general population to the Asian classification. As you can see, the WHO Asian classification has lower cutoff values because based on several studies, some Pacific populations have lower percentage of body fat, and body fat distribution differ at a given BMI than do white or European populations. Let's focus on the values for Asians. For underweight, it's less than 18.5. The ideal BMI for Asians would be 18.5 to 22.9, and overweight would be those 23 to 24.9, obese 1 25 to 29.9, and obese 2 is greater than or equal to 30. We go now to the differential diagnosis for weight gain. Our main objective is for us to determine if the weight gain is primary or secondary. Primary weight gain is fat accumulation due to imbalance between caloric intake and energy expenditure, while secondary weight gain is due to an underlying disease condition. Obesity falls under the primary weight gain, which is fat accumulation due to imbalance between the caloric intake and energy expenditure. On the other hand, endocrine disorders and medication side effects fall under the secondary weight gain. Let's go first to obesity. According to WHO, obesity is a global problem as a non-communicable disease that is observed in both developed and developing countries, growing much in prevalence to be considered a global epidemic. It is a global health problem that must be prioritized since it is associated with multiple endocrine and multiple metabolic disturbances, which could lead to various complications such as metabolic, structural, inflammatory, degenerative, neoplastic, and even psychological. It has been associated with 60 medical syndromes and 12 different types of cancer. Obesity is a preventable, chronic disease that kills a lot of people. Here, we must come in to give out the right patient education regarding this global problem. We, future physicians, must be advocates of healthy lifestyle and be examples ourselves in doing so. Next is edema. Edema is an abnormal accumulation of body fluids that could manifest as ascites, peripheral edema, as you can see here, or periorbital edema. This is a red flag that indicates a secondary weight gain etiology from a pathology either from heart failure, liver failure, kidney failure, damaged leg veins, or damaged or diseased lymphatic system. We now go to the endocrine disorders. Here is a list of various conditions related to hormonal problems in the body, such as Cushing syndrome, hypothyroidism, PCOS, and hyperinsulinemia. We'll be discussing this further later. Next are the different medications related to weight gain as its side effect. This can be observed in patients taking steroids, contraceptives, either oral or injectables, antipsychotics, antidepressants, and anticonvulsants, and drugs for diabetes, like insulin, sulfonylureas, and pioglitazone. Let's now proceed to the next topic, which is history taking. Under the general data, here, statistics show that in the Philippines, 1 out of 5 Filipinos are overweight, and there are two more obese females than males in the Philippines. This graph shows the increasing prevalence of overweight and obesity among adult Filipinos, 20 years old and above, data from 1993 to 2018. So the demographic data of our country shows that females and older age individuals are more likely predisposed to developing obesity. For the other parts of history of present illness, we must consider the onset of weight gain. If it has been over a long time, it is more likely a primary weight gain due to higher food intake than food expenditure. But if the onset is only for a few months, it could be secondary weight gain. Past medical history. There are many comorbid illnesses that can predispose an individual to weight gain, like the ones we have mentioned relating to endocrine abnormalities like diabetes, Cushing syndrome, and PCOS. And also intake of medication, as we have stated a while ago. For the family history, several studies have shown that obesity has a genetic predisposition to if parents are obese. More likely, the patient will experience weight gain more easily. Social and environmental history is of important value. Here we can assess the eating pattern and physical activity of the patient. We could pinpoint unhealthy lifestyle that could lead to the development of obesity, like unhealthy diet, sedentary living, and even excessive alcohol consumption. We now go to the review of systems or ROS. Here are infographics that could help you remember the signs and symptoms that are classic presentation of these endocrine abnormalities. For Cushing syndrome, you could ask if the patient noted any easy bruising in his or her skin, menstrual abnormalities or infertility, joints or back pain. For brittling of the bones, ask if the patient gets easily tired and if he or she has insomnia. Patients with Cushing syndrome also experience memory and concentration problems, as well as mood problems like depression. For hypothyroidism, ask if patient experiences extreme fatigue, intolerance to cold, lethargy, dry skin, constipation, and also menstrual abnormality like amenorrhea. For PCOS, ask the patient for irregular menses, pelvic pain, weight gain, frequent headaches, and decreased libido. As for diabetes, the three P's of diabetes should be asked. These are polyuria, which is increased urination, polyphagia, which is increased appetite, polydipsia, which is increased thirst. So these are the things you have to ask for in the ROS relating to possible endocrine abnormalities in the patient. We now move on to physical examination. First, we do the general survey of the patient. Here are the classical presentations of different endocrine abnormalities. First is Cushing syndrome. Here you see a round and bloated face, which is a typical moon phase of a Cushing syndrome patient. Acne and excessive hair growth or hirsutism is also prominent. Build-up of fatty tissue around the abdomen, the so-called central obesity. The build-up of fatty tissue around the neck, which is buffalo hump. The loss of muscle tone, resulting in thin arms and legs and reduced muscle power. Stretch marks or striae, as you can see here in the arms and the abdomen, indicates the thin and fragile skin of the patient. For hypothyroidism, what is shown here is myxedema, seen in severe hypothyroidism, where you would note the hair is dry, coarse, and sparse, and the lateral eyebrows would be thin. There is periorbital edema, puffy dull face with dry skin. Next, for PCOS, you have to note for also central obesity, hirsutism, acne, male androgenic pattern of alopecia, and acanthosis nigricans. We now go to the anthropometric measurements. First is the waist circumference. The proper way of taking the waist circumference is at the level of the navel or umbilicus. It should be taken while the patient is standing, relaxed, and in exhalation. Here are the must-know values you have to memorize to indicate that the patient is already at a health risk. For men, greater than 40 inches waist circumference is a health risk. For women, greater than 35 inches is a health risk that indicate an excessive abdominal fat. For the waist to hip ratio, the hip is measured at the widest circumference around the buttocks. The greater the waist to hip ratio is, the greater the abdominal fats. For men, we must be worried if it is within 0.9 to 1, and for women, if it is 0.85. These values indicate that they are in a higher health risk. So remember, for the PE, you can already observe through inspection if the patient has possible endocrine abnormalities. And you can do anthropometric measurements like that of the waist circumference and waist to hip ratio to check the abdominal fat of the patient. I would just like to add this to our discussion. The behavioral approach of prevention of obesity. I believe that if we fully educate our patients well about the importance of changing our behavior and preventing obesity, we will be able to solve the global health problem it is causing. Obesity affects all age groups. The effective prevention of adult obesity will require the prevention and management of childhood obesity. So it is very important to start patient education from childhood through the guidance of the parents. As future physicians, talk to the parents well about the importance of advocating healthy lifestyle in the family. First thing you have to bring awareness to the parents are the adverse health effects of excessive and uncontrolled weight gain, which could develop into obesity. And obesity has a lot of complications from heart disease to unfortunate cancerous conditions. Second, you have to bring awareness about the ways of healthy living. And here is an infographic from WHO, the ABC to obesity prevention. A, adopt new healthy habits, and these include regular exercise, balanced diet, and involvement in sports. And bad habits would be binge watching and eating too much fast food or junk food, which should be avoided. And letter B, balance your calorie intake. Advise your patient to have a food diary, taking note of the intake, the calories in, and output through physical activities, calories out. C. Control weight gain by monitoring and employing strategies of proper diet and exercise. These may sound basic, but it is a very fundamental approach to prevention of obesity. I would like to end my presentation with a quote from an inspirational speaker, William Arthur Ward. Here it goes. Believe while others doubt, begin when others are procrastinating, persist while others are quitting. This is for your patients who are trying their best to manage their weight. Please be their number one supporter. Always boost them and remind them to persist and never give up in doing something that their future self will thank them for. For you, as a medical student, always believe in yourself that you can be the greatest physician someday. Begin changing for the better while others are not. Persist despite all the challenges the study of medicine brings upon you. Rest if you must, but you should never quit. Thank you for listening. Hope you learned a lot from my discussion.